All right, my voice is going to be very loud. I cannot control the audio. Okay. First of all, no practical class, no tutorial this week. All right, and next week we're going to resume. We have our last practical class next week, and also we also have tutorial next week. And plus, regarding to the assignment, I think there are people who did not submit your assignment. So I already reposted the announcement on eLearn. Those I think is 9 students on the list. You must do your assignment within 1 week. I also give a deadline on the announcement. So if you do it, good. If you are not, that's it. And you cannot come back to me after your final exam and ask me that whether you can compensate with anything that to make up the mark for your assignment. It cannot. It will be too late, because after your final exam is going to submit, actually to tailor your all the mark and also submit your final mark to the exam unit. So there's no time for doing the assignment again. So for those 9 students, you have to do it within this week. I'm not sure the deadlines, I think, should be also in this week. All right? Okay. So today we have the second part of the microbe disease and resistance. So we're going to introduce you our immune system. Right. So our immune system, as you all know that we have 2 types of immune system. One is the innate immune system. The other one is the adaptive immune system. Right? Which immune system produce antibody? Anyone know? We have the innate immune system or innate immune response and the adaptive immune response. Adaptive, correct. Adaptive is the one that is a long-term immune response that it actually can have the memory of the pathogens and also produce antibody. So today we're going to cover the first thing is that we're going to introduce you cells, tissue, organ which are the part of the immune system, and also we start talking about the innate immune system, including all these 3, which are the component and also the hallmark for the innate immune system. All right. Yeah. What you have to know, I think there's a lot of things that you need to know today. That you need to know what kind of cells, tissues that are involved, or organs that are involved in the immune system, and also discuss what kind of molecule. This is a small part. So our host, even human cells, they can release antimicrobial substance that against the pathogens. So you need to know what are those, and you can maybe memorize 1 or 2. And then after that, you need to start to let you know what is the complement system. You may not heard about very often about this, but this is part of the immune system, and they are important too, although they are not acting directly to the pathogens. And here explain the mechanism of phagocytosis, which is very important. And finally, inflammations. Inflammation is a syndrome that you see during how our immune response to any injury or infections. These are good things. All right. So you may have to see to define what is immune system. So immune system is a defense system that the host against the pathogens. So it's use a few organs, tissue cells that what they can do to eliminate or to kill the pathogens and to remove its product. So this is our immune system. And what is immune response? Immune response is a response that generate through the immune system that against the potential pathogens. And also immunity, sometimes you also hear about this one, is normally referred to the ability of the host, right, to resist or to resist a disease or to remove a pathogen's the ability to do that. There are two types, as I said earlier, innate and adaptive. So if you look at that, the main difference for an innate immunity or innate immune system, adaptive immune system or adaptive immunity is when do they appear. So innate immunity appear very early when you have an injury, let's say you have an injury or you have infections at the very first 12 hours, you will have this innate immunity occur. So there occur is that there is a defense system covered under this innate immunity. First of all, the skin barrier or epithelial lining barrier, just to protect, not allow the pathogens to go into the blood circulatory system. And also you have all these phagocytes, right, to engulf the microbe or pathogens. And of course, you have this complement, part of the complement protein or complement system, and the NK cells. What is NK cells? Natural killer cells. Okay, just to add, to kill, to remove all the infected cells. So this happened at the first 12 hours, roughly. And if you want to have the adaptive, it takes time. So it will only occur after days, right? The most that is after 1 week later. And you have the productions of the activations of the B cells and T cells. So B lymphocyte, T lymphocyte. And to produce antibody and to produce the effector T cells. So those are the adaptive immunity. This part will cover in next chapter, the very last chapter. So here say that the other one is the time. They have the response to the injury or infections is different in times. And they also respond differently. This is non-specific. Any kind of invading pathogen, doesn't really matter what they are. They actually will have the same kind of strategy against them, right? The other one is more specific and depends, they can recognize particular pathogens and then they actually can protect using, and then they can store it in the memory for that particular pathogens. And once the second infections comes, they actually can recall and defense from the particular pathogens. So this is specific, this is non-specific. To talk about the immune system, doesn't really matter. We start with something we need to talk about is the organs and cells or tissue that produce all those immune cells. This is not particularly for the innate immune system, but in fact, we talk about how they produce T cells and B cells as an example. Now, if you look at that, all the hematopoietic stem cells, those cells that is a stem cells that eventually differentiate into all different type of immune cells called hematopoietic stem cells. They are originated from the bone marrow, right? So, as the example given here, B cells and T cells how B cell and T cell also part of the immune cells, right? They also coming from the hematopoietic stem cells from the bone marrow. So it's a precursor cells, and they can, because they are the stem cells, polypotent meaning that polypotent, then they have the ability to differentiate into different cell type. So it's called polypotence. And once they proliferate, the precursor cells that going to sort of like develop into T or B cells. So then the T cells will move to dimers, B cells will remain in the bone marrow, and this is the first so-called, these two are called the primary lymphoid organs. Right. This is when you will start to hearing a lot of terms called the maturations of T cell and B cells. I will explain what is maturation mean. And then when they become mature, T cell, B cell become mature, then they will move to, but they are still naive, they will move to the secondary lymphoid organs. So this secondary lymphoid organ include lymph node, spleen, dorsal tissue in various mucous membrane layer. Right? Those are the localized tissue, and they are considered as a secondary lymphoid organs. Why they are important? Why they call it as secondary? Because T cells and B cells is going to be activated. So activated and then expand. Expand meaning they proliferate a lot of that and differentiate. Start to. That means the activation. Maturation in the primary, activations in the secondary lymphoid organs. Now, you will have to see this one as well, lymphatic vessel. Lymphatic vessel actually is how that connect to the immune system. Very important because some of that antigen present immune cells, some of the immune cells, and also the pathogens, they actually been transferred to the secondary lymphoid organ through the lymphatic vessel. So it's considered, the lymphoid system is considered part of the immune system. Everyone clear? You might have to just memorize what I'm talking about, the primary and secondary. This is the organ where you have your T cells and B cell develop. When we talk about how we make our T cell, B cell, of course, everything is starting from bone marrow, right? So when bone marrow is just making, is a stem cells, is a precursor cells. But if you want to get B cell, T cell become mature and become functional, you have to go through primary and secondary. Oh dear. Right, this is how the maturation occurs for T cells. Primary lymphoid organs, where the T cell will be transferred to, is the dimers. So where is the dimers? Somewhere here, right? I think here, just above here. So here we have the dimers. And the T cells originally in the bone marrow. It could at the back, it could be here, and they will be transferred through the blood circulatory system to the dimers. So once they transfer that, now what happens is that I better use this. This is explanations, so I better use this to explain. So this is from bone marrow. So they will be transferred to the dimers. So when they've been transferred, they are still not, actually they call it immature still as the dimocyte. And in the dimers, they're going to make their T cell receptor, TCR. So this is called T cell receptor, and in short is TCR. Also as well as the CD4 and CD8. Now, why this is important that they have made the T cell receptor? Because T cell receptor is going to interacting with a so-called inlator, interacting with the antigen presenting cells. This is another term, APC, antigen presenting cells, very important. Example of APC include macrophage, dendritic cells, Why they're calling antigen presenting cells? Because they are presenting antigen to T cells. In dimers, this is dimic epithelial cells. They are also one kind, although later on they will not actually will not doing anything anymore, but at the point when they are in the primary lymphoid organ, they are important, right? What happens is that they are, when they actually, the T cells having this, making the T cell receptor, then they're going to interacting with these dimic epithelial cells. These dimic epithelial cells going to having a so-called MHC molecule. This is MHC molecule has class 1 and class 2, two type. Now, this MHC molecule, I'm not sure whether you heard about that, some of you may heard about that. They are used to presenting antigens. When I call presenting is that antigens will be generated in the APC cells inside in the cytoplasm and then being transported to the cell surface, and then they're going to conjugate with MHC, and MHC holding the antigen on the surface. So MHC is important when they are holding the antigen on the surface. And this antigen holding the surface later and will be interacting with T cell. But at this point of time, there is no antigens. These primary typhoid lymphoid organ do not have any antigens present yet. All right. This is only for maturations. There is no antigen. Always remember, this is antigen independent phase. Now, what happens is that they also need to have the TCR need to interacting with this APC. So this is dimic epithelial cells. They also have the MHC. They need to have the interactions. And how they interact to decide if they are presenting class 1, they will be interacting with CD8. If they're presenting class 2 MHC, they will be interacting with CD4. In that case, they will eliminate either one, CD4 or CD8 eventually. But here they have to do a selection. What is the selections? So it's called positive selections. It happens in the cortex of the thymus. When the T cell receptor, this TCR, they recognize the MHC here, then they can say that they can actually interact. Important is that these particular T cells must be able to recognize MHC, either class 1 or class 2. So if they recognize, then they will be screened. Okay, they are not going to remove them, they survive and proceed to next step. So for those TCR cannot recognize the MHC on the surface, then they will undergo apoptosis because no use. The first thing is you have to induce to activate the T cells, the first thing they need to interact with the MHC. So this is a selection step. They're selecting those T cells can recognize MHC. For those cannot recognize, they remove. So this is so-called positive selections. Right. When those are eliminated, those can interact with MHC, they move to the thymus medulla and they will undergoing the negative selections. So these negative selections, they have another screening, meaning another training. You know that for AI, sorry, I'll just make an example. For AI, a computer, if you want the computer to actually to do a job, you need to train the computer. For example, face recognitions. So you have to provide many faces to train the computer to recognize accurately the faces. Same thing here. Which one? Same thing here. You are training the T cells. First thing, you're training the C cells to recognize MHC. Secondly, you're training the T cells not to recognize self-antigens. Self-antigen is not really the antigens. Antigens normally refer to pathogens, but self-antigens are our own protein. So those molecule or protein that produce from the host, from human, let's say. So of course, our T cell and B cells should not target on it, on those own cells protein. So they can only target on their foreign protein or foreign molecule. So in the second part, negative selection is that T cell TCR that do not interact with the self-antigens, which is self-antigens coming from our own body, right? If they cannot recognize, then they can proceed and survive. If those T cells, just randomly, let's say they can interact with our own protein, that cannot, but then they can to remove those T cells. So those T cells will undergo apoptosis. So screening 1, screening 2, to train the T cells in future, when they activated, they can recognize MHC molecule. Secondly, they will not recognize the self-antigens. They will not recognize our own protein, cells protein. They will only recognize the external protein or external pathogens. Clear? Okay? Yes. It will proceed after this part. It will, yes, if immediate after that. It all happened in the dimers. Mm-hmm. So, already they have macrophages. Yes, in our body we have macrophages. So this is macrophages. Macrophages and dendritic cell is APC, antigen presenting cells. Yeah, they do present, and they somehow will actually take this as for training for having this antigen presenting by the macrophage. Actually, it's not really macrophage and dendritic cells. I believe it's also the dimer epithelial cells presenting the self-antigens, that it can train the T cells that it's not going to recognize the self-antigens. Yeah. Now, after this training, they become mature, but they are immunocompetent. They so-called mature and also called immunocompetent, but they are still naive. So you will heard about that T cells, naive B cells is talking about here. They are mature, but they are naive. Naive meaning that they still cannot recognize the antigens, any pathogens coming from outside. They are not yet be able to do that. Therefore, they are called naive. All right. Now, what happened is that, just to talk, after this part, they will move to the secondary lymphoid organ. In the secondary lymphoid organ, after this, they will be activated. All right, they will be activated, and then meaning that they become fully functional. But that part, I will leave it to the last lecture. B cells maturations. B cells actually produce a lot, proliferate in the bone marrow as a precursor cells, and then they can become mature in the bone marrow as well. So the primary lymphoid organ of B cells is in the bone marrow, not in the dimers, but in the bone marrow. So it's much simpler because here, similar like T cells, they're going to actually have this progenitor, meaning precursor cells. They first become the pro-B cells, which is ready actually under the gene level. They actually make the combinations of this segment. So VDJ is a variable segment for the heavy change, and VDJ again, there is another one for the light chain. So they will making their B cell receptor. So during the maturations, they're making the B cell receptor. All right. Now here, they will actually eventually they're making the IgM. IgM is the very first antibody, and that produced by B cells. So in this case, let's say it's IgM they produce. So this become, and then they will become mature later on in the spring or lymph node. Here, important, they're also undergoing some training. So they have been trained to recognize cells and non-cells. So they also been telling the same thing that the B cell receptor, right, cannot bind to their self-antigens. Right? If they do not bind to the self-antigen, then they proceed and they become mature. Negative selections, if the B cell receptor interact with the cell antigens, meaning that we cannot have these B cells remain because it's recognized its own protein. And if it's recognized our own protein, later on you'll be in trouble because it's going to generate antibody that against our own protein, and it's in trouble. Why? If our body, the B cells generate antibody, start to attacking our own protein, meaning that the protein on the tissue, on the cells, so actually attacking the cells and our own tissue. This is exactly what happened to those so-called autoimmune disease. So you will have autoimmune disease when your own immune system start to attacking your own organ or tissues. And this is created because there are something wrong during this selection part. They are not accurately do the right selections. Eventually, B cells or T cells recognize self-antigens and bind to it, and then order our immune cells to produce more B cells and then making more antibody. So it starts attacking our own tissue and cells. And therefore, this selection part are very important. All right? So this is how the maturation happen. Talking about how they actually go into the secondary lymphoid organs. We start to introduce what is the so-called lymphoid system. So it contains two things. One is the lymphatic capillary or lymphatic vessel. The other one is the lymph node. We have 500 to 600 lymph nodes in our body, and then they all are connected with the lymphatic vessel. Why lymphatic vessel is very important for immune system? Because lymphatic vessel collecting the fluid, right, from the tissues. So let's say that we have in the gut, right, the gut that lying underneath the epithelial layer, there are lymphatic vessel, and those fluid, whatever the nutrient, whatever maybe the bacteria from the gut coming out, let's say that they will go into the collected by the lymphatic vessel. So these lymphatic vessels will be circulating to the lymph node. And there is only one direction for the circulations. So this is the lymphatic vessel. So they have the valve, which is actually in this kind of structure. So the fluid will only come going from one direction, coming in this way. They wouldn't be actually, no way they can actually moving from opposite directions. So when they are flowing here, if let's say there is infections in the tissue, and that is a bacteria colonized in the tissue, bacteria will also being collected, flowing into the lymphatic vessels. And these pathogens will bring into the lymph node. Also, there is the cells, let's say macrophage, because there is infection in the tissue. So not only the bacteria, but those macrophages, they engulf the bacteria here. They also go into the lymphatic vessel and bring into the lymph node. So here we go. When antigen-presenting cells such as macrophage, dendritic cells, they engulf the bacteria. They bring the bacteria, whatever the pathogens, into the lymphoid system, and they will pass and go into the lymph node. So this is one of the lymph node, and is considered as one of the secondary lymphoid organ. Here, T cell and B cells is going to encounter the APC cells, antigen presenting cells, or the antigens. So where the antigens or APC cells come from? So they're coming from the lymphatic vessels. So they're coming from here or here, these two lymphatic vessels into the lymph node. Right? So they're going to hear from in this lymph node, they don't encounter the T cell, B cell. So where the B cell, T cells come from? So B cells and T cells, when they become mature, they're coming out from the primary lymphoid organ. They will go through again the blood vessel. They will come to this secondary lymphoid organs. So B cell, T cells coming through here. Well, they are inside this lymph node. They have, for T cell, B cell have different localizations. B cells will be present, localized or reside in the cortex, and T cells will be in this paracortex, or you call T cells regions. So T cells will be localized here, B cells will be in the cortex, in the follicle. So they will encounter here, say that B cell, T cells going to meet the microbe or APC. So what happens is that APC cells is going to present the antigens, which is coming from the bacteria or microbe, to the T cell and B cells. When they're presenting the antigens, or B cells directly meet the microbe, T cell, B cell will be activated. So this is how the activated come from. Actually, activations of B cell, T cells coming from the secondary lymphoid organs. What happened after the activations? This is B cells, T cell activation, okay. So this is the consequences of when they encountered the microbes or the APC cells in the secondary lymphoid organ. For B cells, this is the bacteria, right? Look like bacteria. And then it's sort of activated, okay. They can have two ways to activate it. One is the thymus independent activation, meaning that without T cells, it can activate it. It expands the clonal expansions, meaning that T cells start to proliferate a lot and then differentiate into plasma cells. So remember, plasma cells are the cells, the mature cells that produce antibody. And if the B cells require, there is another population of B cells require the T cells, okay, and then it can also make into the memory B cells. So those memory B cells are important because they already has the informations of the antigens. So they will not produce in a large amount, but those are the memory cells. Okay, you have the clonal selection or expansion for T cells. This is helper T cells, cytotoxic T cells. And they are two different types of T cells they consider T cells, but they are two different type of population, carry out different functions. And what are their functions? We will talk about that in next lecture. But here you say that wherever in the secondary lymphoid organ, when they encountered the microbes or bacterial pathogens or APC cells, they will actually become the effector T cells, meaning that they are fully functional, right? Or memory T cells. So these are the helper T cells. And also for the cytotoxic T cells, again, that they have, this is infected cells also considered as APC cells, and they actually presenting the pathogens, antigens here. So these antigens will activate the cytotoxic T cells, and they become effector T cells. They proliferate, expand in number, and then they start to killing the effector cells. So this is how they are actually expand in populations and activated, and they become functional. All right. Talking about the secondary lymphoid organ, there are more than the lymph node. The secondary lymphoid organ also includes spleen. Spleen actually similar to the lymphoid, and each of the is also going through the spleen, and spleen also actually can collect all the microbe or antigens, but different from lymph node. in case of lymph node pathogens or antigens actually going into the lymph node through the lymphatic vessel. But for spleen, when you have the antigens go into our blood circulatory system, and those microbe or pathogens or antigens can be bring not to lymph node but to the spleen, because they are through the circulatory system. They go here, and then there will be the T cells, P cell reside inside the spleen and activating the B cell, T cell here. Right, so there is another type we so-called mucous gut associated lymphoid tissue. This is also a secondary lymphoid organ. It's a place where T cell, B cell can be activated. How? When you think about spleen, tonsil, which is here, and thymus, which is here, they are actually individual organ, and they are very far from the gut. So in the gut or other respiratory tract, urogenital tract, they are very far from other secondary lymphoid organ. Therefore, they purposely, I think evolutionally, they actually make up another secondary lymphoid organ in those tracts. Those tracts actually secrete the mucus. So an example is the intestine, our gut, also have this so-called mucus or gut-associated lymphoid tissue or MOT. So what happened here? So this is the epithelial lining. This could be a lumen, right? Contain a lot of food. Of course, contain a lot of microbe. So all these microbes, when they become increase in number or become infectious, they actually can be detected. This is the so-called secondary lymphoid organ present beneath the epithelial lining. So here there is a dendritic cells. Dendritic cells actually can extend its the sort of part of it. It's not a hand, but it's kind of considered, and hand that actually extended to capture the microbe. So this is how they capture the microbe. Or the microbe can go into through M cells. M cells is called microfold. So through in here, it will bring in, because this is the epithelial lining, there is a lot of barrier protecting, not allow them to go. They can only go into M cells, which like a donut shape of the cells here without the cilia. So easily that microbe capture here, transported here. There is a lot of these phagocyte dendritic cell waiting here for them to come. So when they come, immediately they engulf and they bring into the follicle, which they will encounter the B cells, or they will bring to their T cells regions that they will actually facing, interacting with T cells, and T cell, B cell will be activated. All right, this is another secondary lymphoid organ. Now, change the topic a bit. We finished about what is so-called primary, secondary lymphoid organ. Now start to introducing you what is those immune cells. So cells for the immune system, hematopoietic stem cell, HSC, that everybody know. They are the polypotent stem cells. They can proliferate and then eventually can differentiate into many types of immune cells. So they are actually present in the bone marrow. And those process for cell proliferation and differentiations happen in the bone marrow. We call that hematopoiesis. All right. Now, what is observed here is that when you are the infant or newborn or infant or baby, and the bone marrow is in red color. The bone marrow is in red color. But when you come to the age of 25, it starts to convert it into yellow. So this yellow bone marrow, because why is yellow? Because containing fat. So they have been lacking. That means that when you are aging, you start to produce less and less hematopoietic stem cells. So that's why when you're getting the older, elderly adult, they are weak in their immune system because they are no longer be able to produce the hematopoietic stem cell effectively. And therefore, this is another reason also contribute the development of cancer. We know that our immune system actually can protect human from developing cancer by destroying the cancer cells. And because the number of the hematopoietic stem cells drop, and then there is lacking enough number of the immune cells, especially natural killer cells circulating in our blood vessel to protect, to detect any cancer cells, right? And to effectively destroy the cancerous cells. And that's the reason that the elderly people start to easily get cancer. And one reason, of course, the mutation in the cells is contributing another factor. But this is the drop in our immunity is also another factor. Okay, now, basically, they actually divide the hematopoietic stem cells into myeloid or lymphoid stem cells. So there are two big classes. So those are the two big classes. You might have seen that before. So this is a multipotent or hematopoietic stem cells. And then you have divided into the myeloid stem cells or lymphoid stem cells. Lymphoid stem cells is very clear. So basically, lymphoid stem cells include T cells, B cells. So those T cells, those are the B cells, right? They are the small lymphocyte, and also the natural killer cells. So only three types: natural killer cells, T cell, B cell, belong to lymphoid stem cells. However, in the myeloid stem cells, you have those, megakaryocyte and platelets. Eventually, they differentiate into platelet. And you also have the red blood cells, mast cells, myeloid plus. This myeloid plus even can differentiate into basophil, neutrophil, eosinophil, and monocyte. And monocyte will be, they are all circulating, most of them circulating in the blood system. And monocyte eventually differentiate into macrophage and dendritic cells. So can you tell me, myeloid, which cells in the myeloid classes they are phagocyte? Which one? Macrophage is phagocyte because the structure look like phagocyte. Dendritic cells look like because they are reaching out to catch pathogens, look like. One more. There is another one, neutrophil, is also a phagocyte. They can capture pathogens and kill pathogens. So basically neutrophil, macrophage, and dendritic cells. That's why you can see that the percentage. So the percentage that I written here actually is a percentage of these cells in so-called in the white blood cells, leukocyte. So the white blood cells, when you're actually in the white blood cells, other than the red blood cell, of course you have white blood cells, including mast cells. Right? This is a percentage. You will see that neutrophil in a big percentage. Other than, of course, T cell, B cell in this percentage, but this is also in a huge proportion in the percentage because they are very important that they're killing the pathogens. Mast cells, basophil and eosinophil, they are those actually react to mostly to the allergens. So if you have allergic molecule coming in, it will induce the production of mast cells. Mast cells normally actually it is actually reside in the tissue. So when you have the allergic reactions on your skin, probably is actually have inflammations, become red, actually is caused by mast cells. So, but the other one that react to the allergic substance, eosinophil and also basophil, they are reside in the circulatory system. So they are circulating in the body. Mast cells is normally present in the tissues. All right. So to just simply introduce, I think, a few of them, this is the dendritic cells and macrophage. I group them together because both of them are coming from monocyte. So monocyte is a precursor for dendritic cells and macrophage. So monocyte also produce in bone marrow, but then eventually they are circulating in the blood. They're circulating in the blood. This monocyte, they itself also can consider is a phagocyte. They has the ability to engulf the pathogens as well. But they also making into dendritic cell and macrophage. They can themselves have the ability as being antigen presenting cells. So these three, monocyte, dendritic cell, macrophage, can act as antigen presenting cells. Remember when I talk about APC? They are important because when they engulf the pathogens, they then destroy the pathogens inside the cells, and then a fragment of the pathogens will be presenting on the cell surface. So when they're presenting the antigen on the cell surface, it's for the purpose to be recognized by T cells or B cells. All right. At the same time, when they actually are presenting the antigen, they also can produce different cytokine. The purpose of produce different cytokine, we know that cytokine is protein, but it's an inflammatory protein. They make a lot of cytokine. The purpose is to recruit more macrophages, maybe recruit more immune cells to actually come to kill the pathogens. So actually stimulating their productions of more immune cells and cause inflammations. And important here, you see they are in the body tissue. Normally they actually distributed in different tissue so that they can act immediately when there is infections, right, at the different regions. So they reside, and they have long life because they're once they produce, they can stay as a dendritic cells macrogen for months. As this one actually in comparison with another macrophage. This macrophage neutrophil, they are slightly different from, first of all, the shape is slightly different. Of course, they can engulf any pathogens. These are the ones that taken by the SAM, and actually is already having the candida, the yeast inside the neutrophil. They engulf that too. Now, they actually representing 54 to 75% as the white blood cells. In the large amount, they are very important because they act very rapidly, right, to the site where there is an infection or injury, and they are the first actually macrophage to come to the site of injury and infections to kill the pathogens. And they also in the granule, as you can see, there's a lot of granule here. These are granule that they actually have a lot of this kind of like antimicrobial subcompound like lysozyme, lactoferrin, or collagenase. So they are all used to destroying once they engulf inside the cells, they used to destroy the microbes. Now this is important. They are the first neutrophil, are the first macrophage come to the site of infections. So they act very quickly, normally within the first 6 hours. And to react, they are the first to come. And macrophage and dendritic cells will only come later on. So they come, if they do their job, they can stay a little bit longer to several hours and they die. If they actually are not doing anything, only circulating in the blood, then a few hours, 6 hours later, and they will undergo apoptosis. All right? Here, natural killer cells. Remember, natural killer cells are myeloid or lymphocyte. Is one of the lymphocyte, right? So they are similar. So this is natural killer cells. Natural killer cell has its own functions. Normally, it is not a macrophage. Phagocyte is not a phagocyte. Sorry, it's not a phagocyte. It doesn't engulf the, the pathogens. However, it can recognize the infected cells. Let's say you have virus infect certain cells, and there is no way, once the cells has been infected by virus, there's no way the cells can recover. Probably you need to destroy the cells. So their purpose is to destroy the infected cells because it cannot be rescued. So we do not want the virus to be replicate and proliferate inside the cells. The only way is to reduce the harm. They need only killing the infected cells, right? To stop the proliferations of the virus. So they have 5 to 10%, all right, of the lymphocyte in human blood. And they also differentiate mature in dimers, okay, in spring activated, and they have no MHC. So they are not the macrophage and dendritic cell. This is what they want to say. But they do have the natural killer cells receptor. This is important because this receptor is to use to recognize the infected cell. Let's say this target cells has been infected by the virus, infected by the virus. So these NK cells trying to kill it, and it will have to have a receptor to recognize it. One is bind to the target cells. It start to release two things. One is perforlin, the other one is glycine. Perforlin is a pore-forming protein that is forming pore on the target cells and destroy the cells. And glycine is actually to destroy intracellular component and allow the cells undergoing apoptosis. So defensin is another one that also secreted by natural killer cells. So this target cells is not only referring to the virus infected cells. The cancerous cells is also a target for natural killer cells. So natural killer cells, normally they can detect any cell which are abnormal, right? Like infected is not a normal cells. They can detect and kill and remove those cells. All right. In the immunity, do we have how many slides? I have to go. What time is it now? 5 past 5. Sharp 5. You want to have a break? Yes. I also want to have a break. Let's go for 5 to 7 minutes.
He's basically part of the structure. Is a receptor on the cells, and this what other yeah, the reason why we can
I think it's ironic. It's like, oh, he's my pillar when I'm sad or something. It's like mental help. It's like my mental stability. I think it's ironic. Basically, it was my because this is like wood, right?
Yeah. Can we resume? Anyone is still sleeping? I counted just now. At least there are 10 of you are sleeping just now. Okay, let's start. So this is the second half. I think we have the innate immunity to cover, and then what else? So there were a few. Let's talk about immunity, and then we have the inflammations. Yeah, and then the inflammation is the last part. But there's a lot. It's contained about 18 slides. We go slowly. Don't sleep, huh? Just now I saw a lot of people sleeping. And then you open your mouth very big. So this innate immunity is respond very fast, acting very fast. So it's considered our first line defense. You must heard about the first line defense. It's actually referred to the innate immune response. And of course, it cannot actually like adaptive immunity that have a long-term protective, have a memory, but it cannot. It just respond at the point of time when we got infections. So there are hallmarks we call a feature that in the immune response. So those are considered is the strategy or is the mechanism that protect the human cells or organ tissues. The antimicrobial enzyme peptide is one. The other then can protect the cells is complement system that work together with our immune system to defend us. And also finally is the phagocytotic cells, all right, and the natural killer cells. So those are very important that they are the main component in our immune response. Now, we first talk about the antimicrobial peptide. It's very simple. It's just a peptide that released from human cells that can have the antimicrobial property and they can kill the bacteria, meaning bacterial defensin. Defensin is secreted by human cells and is positively charged. So you can see here, this is a very simple diagram. This is defensin, let's say defensins here. So this is a bacterial. Bacteria have the lipid bilayer. So it's normally this is a negatively charged and they are defensin is positively charged, and then they come along, they interacting with the lipid bilayer, and then they insert it into the lipid bilayer. Why they can do that? Because they are amphipathic. Amphipathic is about that the particular protein, meaning that this defensin is having hydrophobic and hydrophilic amino acid. So when they actually insert it into the lipid bilayer, those are actually in here, they are hydrophobic. Those actually exposed outside is hydrophilic. So the entire defensin in amphipathic. So in this case, when they are inserted, they can disrupt the cell membrane of the bacteria, and in that they can kill it. They produce by epithelial cells, and also they can produce by macrophages and neutrophils as well. The second one, this is not produced by human cells, but it's actually secreted by the normal flora. So this is secreted in our gut bacteria. So our gut bacteria can produce bacteriocin to kill other pathogens that are present in the gut. That's why we consider that the gut flora, they are good bacteria. And same thing is that the bacteriocins that also positively charged, they also, okay, how do they attack? They actually also bind to the lipid cell membrane of the pathogens, and then they create the pore. So once they create the pore, meaning that things can leak out or in, come in, and then the cell bursts. Very simple. Lysozyme, if you remember in the tutorial, we talk about lysozyme. Lysozyme is the one that can damage the cell wall, and actually they are targeting on this so-called beta-1,4 glycosidic bond in the peptidoglycan. So our peptidoglycan are made up with the N-acetyl glucosamine, and also the other glycan is N-acetylmuramic acid. So they are linked together by this one beta-1,4 glycosidic bond. So lysozyme target and break the bond here. So when this bond is breaking up, then it's actually the peptidoglycan cannot maintain its structure, and the entire cell will collapse and the cell dead. So this lysozyme you can find in the tears, mucus, saliva, plasma, as well as the tissue fluid. Now, complement system. This complement system is part of the innate immune response. In our innate immune response, we will produce a lot of protein which are considered as a complement system. So complement system consists of a lot of protein. Together could be more than 30 protein, right? They are present in the plasma. So we can call them a plasma protein mediator. And they actually giving an innate non-specific defense. They work together with other part of the immune system to fight for the pathogens. So they have contained more than 30 protein, including those very well known and common. Is actually C1 to C9. Remember, C is complement, so it have complement 1, 2, 3, 4 to 9. But they also have other, but there are, and actually the entire complement system is very comprehensive and also complicated. So what is their job? Their job is to enhance. They themselves are not directly killing the pathogens, but they enhance the entire innate immunity in order for it to kill the pathogens. Now, this is how it works. It works through 3 pathways: classical, lectin, and alternative. I'm not sure you can see the small letter here. So I just explain one by one. And basically they are doing very similar. It's just how do they target the bacterial. Consider this is a bacterial. How do they target the bacterials as different. So for example, in classical pathway, you will have the antibody. Let's say that there's antibody can targeting of any of the glycoprotein, any receptor on the bacterial cells. So once the antibody bind on it, now one of these so-called C1 kill from this complement. So consider this is the antibody IgM bind, and then C1 kill bind together with the IgM bind to the surface of the bacterials, and this C1 kill and containing one of the domain C1s. So this C1s will activate it and it will cleave C4 into C4a and C4b. So C4b become activated when it's cleaved. So when it's cleaved is activated, it will actually further cleave C2 into C2b and C2a. So C2b by itself, but what happens is that after cleaving, you will have the C4b and also one of the C2a. So this C2a combined with the C4b is called C3 convertase. So it basically convertase is a protease. So C3 convertase. You remember this one? Lectin pathway is similar at downstream, but it is different when how do they recognizing their bacterials. So bacteria again have a lot of sugar, glycan, right? So mannose is one of the sugar present on their bacterial cells. And this particular MBL, mannose binding lectin, can recognize the sugar unit on the cell surface. Those sugar units contain inside the whatever the receptor, the lipopolysaccharide, the teichoic acid, right, on the surface of bacteria or the fungal cell wall. Now it binds to it, and then it's react. When it's bind to it, it start to react with the esterase in the plasma, and it become a so-called mannose associated serine protease, MASP. This MASP activated, one is activated, become a complex activated, it cleaves C4 to C4b to and C4a. And C4b, similar like this, cleaving C2 into C2a, C2b. And then C4b here and C2a combine and become a C3 convertase. This one is the ultimate what they need to produce. Same as here. C3 convertase is the ultimate product. Alternative pathway. This pathway is direct actually contact of C3b on the cell surface of the bacteria. And this C3b will interact with the factor, so-called factor B. Factor B then can be cleaved. Once it's bind, factor B can be activated and it will be cleaved by factor D. So it's produced, this is so-called BB factor. So BB factor will combine with C3b, it actually becomes a C3 convertase. Alright, so actually this complement system, through the different way of binding to the bacteria, they will actually making the C3 convertase. So what happened to this C3 convertase? This is what happened. So you have three pathway, right? Alternative, lectin, and classical pathway. That to start with, and or eventually making this C3 convertase. Now, C3 convertase will split, because it's a protease, it will split the C3 into C3a, C3b. Same thing, when this C3b has been cleaved, it actually can cleave C5 into C5b and C5a. Now, after you have C3a, C3b, C5a, C5b, they having three outcomes. So what happened is that C3a together with C5a act as a chemotaxis that have the ability to help to make a vasodilations of the blood vessel and cause the inflammations. So the first outcome is causing the inflammations. Alright. Second is that C3b can act as a opsonin. I think I will add an opsonin. So it itself can be act as an opsonin, bind to the bacterial cell surface. So once they bind, act as an opsonin, opsonin can be recognized easily by the phagocyte. So phagocyte having, with the help of C3b, then they can engulf the bacterial cells easily. Without this C3b act as an opsonin, that possibly the phagocyte are not able to recognize and make contact to the bacterial cells. So they have the help as being an opsonin. Then lastly, they also can be one of the component C5b here as part of the unit and actually forming, acting itself as a monomer in a very big oligomer. So this oligomer together with other protein from the complement system, I think basically C9, C3, C7, all of this forming a pole and is caused the bacterial cells lysis. Right, so causing inflammations, all right, helping enhance the phagocytosis and also lysis of the bacterial cells. There are the three outcomes coming from the complement system. Now, we have talked a little bit about the phagocytosis, which is very important. And phagocytosis can be done by these few cells: monocyte, macrophage, dendritic cells, and neutrophil. So they can actually make contact with the pathogens, can ingest and destroy. And they also clear the debris, right, of the cells inside the cytoplasm and denature all the protein. And then they will actually excrete it out, some of them. So phagocytosis includes 6 steps: chemotaxis, recognition and attachment, engulfment, phagosome maturations, and phagolysosome formation. destructions and digestion, exocytosis. So altogether there is 6 steps in the phagocytosis. Step 1, chemotaxis. So chemotaxis is something that acting at as a chemical that it can attract the immune cells to the infection site. Let's say there are the site that you have invaded with the bacterial. So there are bacteria growing here. Now, how do the immune cells come here, especially the phagocyte, to come over here to engulf the bacterial? There is some signal sending and then allow them to come over. And those are the chemotaxis. So those attractant that allowed to actually attracting the phagocyte to come over, they are part of those coming from the bacteria, such as bacterial protein, capsule, LPS, all of these can be. And also the complement protein 5, as I mentioned just now, it can be also a chemotaxis agents. And also some of that is released by the affected cells. Those cells here is greatly affected. They actually release a lot of chemokine. So those chemokine can be released into the blood vessel and stimulate all the phagocyte to come over. Now, neutrophils is the one that come first. So they actually come in the first 6 to 24 hours. And then after that, it will only be replaced because it doesn't have a long half-life. And then it will be replaced by the macrophage, which continue to removing the pathogen in 24 to 48 hours. All right, adherence. Adherence, you might have heard about what is so-called pathogen-associated molecule pattern. So it's something that can be recognized by our immune system. So for example, this PAM, we call PAM, this can be the cell wall bacterial, LPS, Flagellin, anything that outside on the surface of the bacterial cells can act as a PAM. And also double-stranded RNA, single-stranded RNA virus can also be part of it. So anything that it will be recognized by our immune system is called the so-called pathogen-associated molecule patterns, right? Those that can recognize this PAM, we call it PRR, pattern recognition receptor. So a very good example is the toll-like receptor. Toll-like receptor present in the macrophage, such as that, it can recognize the LPS. So recognizing LPS specifically, and therefore this toll-like receptor we call a PRR, and LPS we call PAM. So those are the terms normally people will use. What happens is that, so when the adherence happens, they're actually releasing cytokine to recruit more phagocyte. This is what happened. So cytokine is considered such as interleukin 6, interleukin 10. All these are the cytokine. Even the TNF alpha is one of the cytokine. So they are soluble protein and they released by the macrophages or those cells, the infected cells, and they actually will stimulate different signaling pathway. So this signaling pathway will cause inflammations, recruit more immune cells to the site of injury or infections, and this is what happened. So adherence also come with these opsonizations. So opsonizations, as I mentioned, in the complement system, there is C3b acting as an opsonin. So if the macrophage, let's say as a macrophage or phagocyte, here, they may not recognize, sometimes the bacteria have their defense system, like the slime layer. So slime layer or capsule of the bacteria can protect and avoid being captured by the phagocyte. Now, you need the help from the opsonin. So opsonin will bind to the surface of the bacteria, with the opsonin on the surface of bacterial, there is a receptor, so-called opsonin receptor on the phagocyte that can recognize opsonin and bind on the opsonin and capture the bacterial cells, and then it can engulf. Otherwise, the bacteria has also its own defense system, like capsule and slime layer, to be avoided by capturing by the phagocyte. Alright? Engulfment. Simple. You just has the pseudopod. What is pseudopod? This is pseudopod. It's the extensions of the membrane, cell membrane. Right? This is a pseudopod. You see that how long it can extend. So the pseudopod can extend to capture these pathogens, the bacteria here. So they actually like engulfing using the pseudopod, extended and then wrap around and then take in. So when the bacterial cells take in, they are inside a so-called phagosome. So phagosome, and what is phagolysosome? So in this is a macrophage or phagocyte. Now, bacteria come in, they actually is inside the phagosome, so-called. This phagosome has a very low pH and is contain a lot of hydrolytic enzyme. So this hydrolytic enzyme is trying to destroy, of course, at low pH, they are very active and trying to destroy the bacteria. And somehow, they also have another step, which is called lysosome. Lysosome will be combining with the phagosome. So they actually merge these two vacuole together and it called phagolysosome. So, and it will fuse and then it will further damaging the bacteria, killing the bacteria into and break it down, degrade it into small pieces, and then you release it out. So this is what about the destruction and digestions? What is inside the phagolysosome? So phagolysosome is trying to maintain its low pH, maintain its acidic pH, which actually it helps to make a lot of enzyme active. And how to actually they maintain their low pH? So their low pH using the proton pump called ATPase. And it is transport the proton into the, transport the hydrogen's proton into the phagolysosome, and then to maintain its low pH. So it contains, therefore, is activate a lot of hydrolysis, and they actually active in low pH. So those hydrolytic or hydrolysis include defensin, capsaicin, phospholipase A2, lysozyme, and other proteases, which can damage the bacterial protein, peptidoglycan, plasma, and so on. So it contains a lot of enzymes that trying to destroy every single part. Some of these enzymes destroying the protein, some of them destroying the lipase, some of them destroying the polysaccharide. Alright, when they has been destroyed, the last step is the exocytosis, and they try to eliminate all the digestive particle out of that phagocyte. Alright, this is 2 slides only. Will further tell you how the bacteria also have their own way to avoid being engulfed by the phagocyte. So this is the way, just a few examples. There are many of this. I think if you need to list it all, you will have around 10 or 11, 12. But I only mentioned about 4 of them. Now, how do they do this? Some of the bacteria, Streptococcus, they're avoiding contact with phagocyte. Alright, how do they actually avoiding the phagocyte? So if the Streptococcus, they can release called C5a peptidase. C5a, you remember, is a chemostatic substance that can attract the phagocyte. So they're using this peptidase to actually digest it, degrade the C5a. so that they will not attract more of the phagocyte. Another bacterial Staph aureus, they have clumping factor, which make it become very virulent. There are two cooculase. This is clumping factor, is a cell-bound cooculase. Why is it called cell-bound? Because it's actually present inside the cell envelope, the cell membrane. So therefore it's cell-bound. There is another cooculase also released by the Staph aureus. That one is the so-called free cooculase, but it's not mentioned here. So this one is only that cell-bound cooculase. What happened to this clumping factor? It can convert fibrin into fibrinogens, right, normally present in the blood, can convert it into the insoluble fibrin, and then it coated on the cell surface of the Staph aureus. So they actually making their protective shield. They clot themselves inside the clotting the substance, and then with that they can avoid being recognized by their immune cells, being engulfed, because they are clotting, protecting themselves inside the clot. Okay, so this is how they avoid being recognized by the phagocyte. Now, there is inhibitions phagocytic engulfment. How do they do that? The one, this is just I mentioned, if without the opsonine, many of the bacteria, such as they having producing capsule, I think we learned about capsule, right? Capsules is actually secretions of the polysaccharide outside the cells, and they become something that can be avoiding being adhered by the phagocyte. So those are the bacteria who have the capsules. And also same thing, that slime layer. So Pseudomonas also produce slime layer on the surface. Then this slime layer and capsule can help them being engulfed by their phagocyte. Furthermore, once, unfortunately, let's say they have been engulfed, they've been bring inside the phagocyte. They are inside the phagosome. So they are trying not being digested. So one way of not being digested by the phagosome, or because the phagosome will be fused with the lysosome, and once they fuse, they become the phagolysosome, and the bacteria will be degraded inside. So they try to prevent the fusion of these two. So this Mycobacterial tuberculosis, they having this cell wall contain a so-called sulfatide, right, can be released and from the bacterial cell membrane, and then can release from the phagosome and then modify the lysosomal membrane and then inhibit the fusions. So they're using whatever that's present in the bacterial cell membrane, one of the lipid called sulfatide, and then this sulfatide will be modifying, integrating into the lysosome membrane, modifying, changing the membrane structure so that the lysosome no longer be able to fuse with the phagosome. Rickettsia is another one. They will be engulfed inside the phagosome, but then they will be immediately being releasing out from the phagosome. What happens is that when they are present in the phagosome, they have this particular enzyme called phospholipase. So this is phospholipase is to degrade the lipid bilayer. So immediately they go in, being engulfed inside the phagosome, they can releasing out immediately. And here, number 4, this is a direct killing of the phagocyte. This is even more powerful. Those are the bacterial Pseudomonas releasing secreted exotoxin, and also Streptococcus producing streptolysine O that actually can destroy directly the phagocyte. Basically, they can integrate into the phagocyte membrane and make the membrane, destroy the membrane and make the phagocyte die in that way. Right, so those are the 4 examples how the bacteria be able to avoid being digested by the phagocyte. Now, this is the last part, inflammations. Inflammations is something that occur especially during the innate immune response. This is a good thing, meaning that now you know that when you have inflammations, let's say you have fever, right, it's something that indicate good, meaning that your immune response work. If you do not have inflammations, it's a sign of our innate immune response. If you do not have inflammation, meaning that your immunity are not so strong. Right. So actually explaining that is a good thing because it's actually is attempt by our body to restore and maintain the homeostasis after we have the injury or infections. So it also comparing to acute inflammations and chronic inflammation. Acute inflammation is good because when we have a viral infection, normally we'll have the acute inflammations. So it is our immune response work actually to remove the virus. But if this is a chronic inflammation, meaning that we're having the very low level of inflammations, but we are continue to have the inflammations, and this is not good because this is eventually destroying our own cells. A lot of autoimmune disease, sort of the rheumatoid arthritis, they have chronic inflammations in the joint, whereby actually destroying the joint. If you have inflammation for a long term, eventually all the immune cells that actually aggregate in the joint and you start to destroy the bone. So chronic inflammation are not a good thing. Right, so inflammations, the sign of inflammation, normally when you have inflammation, you will actually recognize these four things. Redness, right? Let's say this is a skin. You have an injury on the skin or infections. So I think infections accompany with the injury. You have injury and then you have a bacterial infection somehow. And what happened is that you have the redness showing, right? And you have swelling, edema, and you have heat. Why you have heat? Anyone know? This one I think you can redness. Why you have redness? If you have an injury. Somehow when you have infections on your leg, especially for diabetes patient, they may not aware because normally they do not have much feeling on the leg. They do not recognize the infections, but you can detect when you can touch the leg, you feel the heat. So it's very warm, indicate there is infections. So generate heat. The heat are not come from bacteria. How do you generate heat? We explain later. And also the pain. Of course you will have the pain because it's swelling. The swelling causing the pain. Now, this is a few things that explain why you see pain, heat, swelling, and redness. So first of all, when you have the injury, right? And immediately there is a mast cells, which are explaining the mast cells is one of the cells reside at the tissues. It's also acting that immediate response. What is their response is that first of all, they release the histamine. Histamine is also one of the so-called inflammatory molecules. So when they release the histamine, or can also prostaglandin, and they cause the blood vessel relax. So when the blood vessel relax, this is at the site, right? So they have the blood vessel going. So suddenly there is a relaxation of the blood vessel. So the blood vessel dilated. So of course the flow of the blood slow down at these regions. So this region will accumulate more blood and you will feel heat because blood will accumulate here and the slow down of the blood flow. And also some of the blood may be leaking out, let's say, and you will be accumulate a lot of blood here So you see the redness, and also you feel the warm, feeling it very warm as here because of the dilation of the blood, more blood coming at these regions. Secondly, increase the vascular permeability. What does that mean? The permeability actually coming from the blood vessel. So they increase the permeability that allowed the leukocyte, let's say allowed the macrophage or the dendritic cells that actually coming here, their target is to pathogens. So they're actually coming here, they recognize, and then they will squeeze out from the blood vessel and come over to engulf the pathogens. So this is the increasing the permeability. So how the permeability occur through a process which I will explain. Basically is the contract. This is endothelial cells. When the endothelial cells, right, they have one line next to each other. So when they contract, they become smaller. So they become smaller, that leaving a gap here. So there is a gap. So you will have a hole, allow the whatever the cells, the immune cells coming out from the gap. So this is called the vascular permeability. So as you make the blood vessel become permeable, so you allow the immigrations of the leukocyte. Now you slow down the blood flow, and how the leukocyte coming out. As I mentioned that the cells will actually, the leukocyte, whatever the red blood, white blood cells or macrophages, they can coming out from the blood vessel, right? And the next slide will explain how do they move from here and coming out. It's not just simply they squeeze out as randomly. That is a mechanism to allow them to squeeze out. And this is the mechanisms. Alright, this mechanism is so-called diabetes or extravasations. So what is that happen is that, look at this is a neutrophil, let's say all macrophage, whatever you can imagine. This is the neutrophil. Neutrophil has receptor on the cell surface. This is the blood vessel. So this is the blood vessel, alright? So they are flowing inside the blood vessel and they trying to coming out from here. And then to eat the bacteria here. Now, they have receptor. First of all, they have flowing, they have to try to slow down. So when they try to slow down, they want to hold on of something. What do they hold on is the receptor called selectin. There is selectin P and selectin E. So they have using this salic, I can't even read it. Lewis, I think glycoprotein is another thing that on the cell surface to interacting with the selectin. So this is a transient interaction, may not having a very strong interaction. So they try to slow down. Then they come to here, they are still rolling. So this is a tight, very tight interactions. And it was done by the integrin from neutrophil and the CAM1. So this is a strong interaction. It is completely stop the flow of the neutrophil. They stop here, and then they next using other PCAM, I think this is called PCAM, another receptor on the endothelium cells, interacting with the neutrophil and bring it and squeeze it out from the gap. So all of this squeezing from the blood vessel into the tissue, they all done by the receptor on the endothelium cells. So that's the explanations. So they are actually step by step guiding the neutrophil out of it. It's not just simply they just flow and then there is something gap they saw, they just coming out from here. It's not, all right? It's rolling at the beginning. It's called rolling. In actual fact, are they rolling? May not. Yeah, but they actually try to divide them into different steps. So the very first step is just that the holding here, I think is a transcend. They are not really like firmly hold it, it's still moving, so they call it rolling. Okay. All right, so as a result of inflammations, because inflammations causing the flow of the blood, the flow rate slow down, vasodilations, a lot of fluid coming out from the vessel, including a lot of immune cells coming on the vessel. It make the infectious site swelling, redness, warm, and also last one is pain. So these vasodilations also permeable to deliver the fibrinogens. The fibrinogens, as I mentioned just now, can form a clot. So if forming a clot, a blood clot that can prevent, why are you forming a clot? To prevent the bleeding, as well as there's another purpose, is to prevent the spread of the microbe. Alright? So however, if you actually stopping sealing off these regions, and then you have the pus, which is contains something very concentrated with these cells and body fluid. Sometimes you observe that as well. But however, this kind of syndrome can be reduced by antihistamine to reduce the inflammation, also reduce the inflammation by antiprostaglandin. Secondly, when you have inflammations, I think it will also start to having a tissue repair. So if you successfully remove the pathogens, what happens is that, and you will actually regenerate the tissue, because the tissue has been injured, a lot of cell dead. So you need to regenerate new cells. Then you need to, what happened? First of all, you switch from pro-inflammatory to anti-inflammatory. When there is no more pathogens, you do not need to have any inflammations anymore. So you need to do the regeneration of the tissue or cells. What happened? Then you need to bring nutrient. So cytokinesis is the cell division, proliferation of cells of the skin or mucous membrane, so that the tissue can quickly repair. So you need to deliver nutrient to do so, because cells proliferation require nutrients. And one more thing is the angiogenesis. The angiogenesis is also happen at the same times. So you want to bring the nutrient. Normally the nutrient is bring together with the blood, through the blood, right? So you need to actually develop the blood vessel. So they will have developed through the angiogenesis, they have new blood vessel developed at the site, and they bring in more nutrient, and they can repair the cells. Once they complete this process, and the blood vessel, those they build up additionally, will be removed. And lastly, this is what is sort of like, as a result, this is, we actually recall what we have just learned, that marginations, when the cells, you remember when I talk about those cells, the immune cells try to squeeze out from the blood vessel, and you will have those leukocyte or other that neutrophil that's sticking on the inner cell surface of the blood vessel. That is happen. And also the diabetes, as is squeezing between the endothelium, they are trying to squeeze out. It's a result of inflammations and because of the vasodilations. And phagocytosis also happen, and because you need the phagocytosis to clear the pathogens at the injury site. All right, so those are the result of inflammations. Do I have any more slides? I don't think so. That's the end, right? Yeah.